and welcome to Digest This, where we focus on clinical topics in gastroenterology. My name is Francesca Moroni. I'm one of the gastroenterology consultants in the north of Scotland. Today, we're going to discuss non-variceal upper GI bleeding, and I'm delighted to have with me today Dr. Aaron McGowan, a consultant gastroenterologist and advanced endoscopist at the Royal Infirmary of Edinburgh. Welcome, Aaron.
Thank you, Franz. Pleasure to be here.
So, it's fair to say that what keeps us up at night is the upper GI bleeding, but how common it is that we get cold at night and how common it is that patients with GI bleed present to hospital?
Well, upper GI bleeding in general remains a very common reason for admission to hospital. The BSG very helpfully published a UK-wide audit in 2022, which about 2/3 of NHS hospitals contributed to, and that showed there's approximately one upper GI bleeding admission every 6 minutes. About 10% of those were varices, so if you take those out, that leaves a significant proportion of your non-variceal upper GI hemorrhage. And the incidence is about 134 admissions per 100,000 of population.
So what happens when someone presents with upper GI bleeding? What is our role in that?
Well, we have a very important role as overseeing the care of these patients. However, very often we're relying on our colleagues at the front door to do a good job, because very often these patients will come in via the accident and emergency department. They may be looked after by acute medicine, or some patients may even consult with their GP in the first instance. So it can be a little while before they become aware of us. And I think the important thing to remember is that all of those initial steps, recognition, diagnosis and appropriate initial management, are arguably more important than the bits that we will do as gastroenterologists later on.
And so what do we think is the most important things in the management of GI bleeding that actually makes changes on patient survival?
That's a good question. So I think we really need to risk stratify patients, and there are several ways in which we can do that. We need to appropriately resuscitate them and look at peripheral factors such as are they on anticoagulation, and careful management of their comorbidities. When the population in the UK is now aging and increasingly comorbid, and so there's often a lot more to think about. These patients are not often presenting with GI bleeding as an isolated problem that you can fix and move on. And certainly we find in Edinburgh that after you've managed the initial episode, the comorbidities are what keep people in hospital before they can get out. So it's about recognition of the problem, but taking that as part of the overall patient comorbidity package.
So what do you mean by resuscitations? What should we do?
Okay, so these patients will need initial assessment, clinical examination, clinical observations. Most importantly, we're looking for any evidence that they have shock with hypotension, systolic blood pressure of less than 100, or tachycardia. We'll need to have some blood tests, make sure that they don't have anemia, and that will determine whether if they do need resuscitation, whether that's with fluid or blood products. Patients might be anticoagulated, and we'll have to think carefully about what to do with that, because often there's a good reason for them to be anticoagulated, but clearly if they're having significant upper GI hemorrhage, it's not in their interest to be anticoagulated at that time.
In terms of blood products, do we have a target we should transfuse patients?
Yes, so there is growing evidence and some good quality data now that a restrictive transfusion policy rather than a liberal transfusion policy, aiming for a hemoglobin of above 70 or 90 in patients who've got cardiorespiratory compromise, leads to better outcomes. And it also, very importantly, saves on transfusion products, blood products, which are a very limited resource both in the NHS and worldwide.
You talked about risk stratification scores. What should we use pre-endoscopy?
Yeah, that's a good question. So the Rockall score has been around for many years now. It was devised in the 1990s, and that aimed to predict mortality of upper GI bleeding and also the risk of rebleeding, but it does require endoscopic findings, so perhaps not so useful for the front door. The Glasgow Blatchford score, which was devised in 2000 by a public health physician here in Glasgow, is very useful at the front door, because what that does is it allows us to predict the need for intervention. And so If somebody has a Glasgow Blackford score of 0 or 1, they can be safely discharged for outpatient management.
So when is the time for us to do an endoscopy?
So we will all have had the experience of being phoned before the blood gas is even back when the patient comes into accident emergency department. And what we know, and there is a reasonable body of evidence for, is that upper GI bleeding is not the same as trauma bleeding. You don't need to immediately turn off the tap. It's intermittent, and it usually will stop by itself. The key thing for patients, and particularly those with comorbidities, is that they are appropriately resuscitated with fluids, blood if required, and attention to anticoagulation pre-endoscopy. And there was a big study led from Denmark several years ago where they showed that particularly for patients with higher ASA grades, if you rush into endoscopy and do it very early before they're adequately resuscitated, there was a trend towards higher mortality. Equally, if you did it too late, there was a trend towards higher mortality. So the sweet spot seemed to be somewhere within 12 to 36 hours, which in practice for us means that we can resuscitate the patient. If they are responding, do an endoscopy on the next available endoscopy list. Of course, there will be a small subset of patients who are not responding to resuscitation or who have ongoing active bleeding and shock despite resuscitation. And that's a different kettle of fish, but it's a very small minority of the people who present with upper GI bleeding.
So where do you think patients should be looked after before endoscopy?
Okay, so I think most importantly, it's important that it's a place of safety where the staff can recognise signs of deterioration and understand how to manage GI bleeding and the resuscitation. In practice, that's very likely to be a medical admissions unit or a gastroenterology ward. For some of the sicker patients who need intensive resuscitation before they have an endoscopy, that will be in a critical care environment. Although, again, as we know, access to those is limited because of competition from other sick patients.
Which lesion should we treat endoscopically?
Okay, so I think if you have active bleeding, that's an easy one. You should try to treat that. Then it depends on what the underlying lesion is. Most commonly, it's going to be peptic ulcer disease, and for that we use the Forest classification. Forest classification is split up into Forest 1, 2 and 3, with Forest 1A being spurting arterial bleeding and Forest 1B being active oozing. And of course, both of those lesions need treatment. In Forest 2 lesions, a 2A has a non-bleeding visible vessel, and that requires treatment. A 2B is where there's an adherent clot. And that's a bit more controversial. I know lots of people feel comfortable just leaving the clot alone and thinking that nature's done its job in that situation. But I personally would remove the clot, see what's underlying that. If you have a clean-based ulcer underneath that, that's fine. You don't need to do anything further. If you have precipitates bleeding or you have a non-bleeding visible vessel, then you know that you should treat that lesion. And a Forest 2C is where there's a pigmented flat spot in the base, and that does not require treatment. Although it can be very difficult, even for experts, to differentiate between a non-bleeding visible vessel and a flat pigmented spot.
So we have stratified our patients. We have resuscitated appropriately, looked after the anticoagulation side of things. We're taken for an endoscopy. We find lesion. So what should we treat, and what modality do we have to treat non-variceal upper GI bleeding?
Okay, so this is the bit that we all enjoy. So I think we know that in about 30% of patients who have non-variceal upper GI bleeding, the underlying etiology will be peptic ulcer bleeding. It's decreasing, probably because we're much better about testing and treating for Helicobacter pylori, although we still do see a significant proportion of that. So that's your most common pathology, and the treatment for that should involve dual endotherapy with adrenal injection and either mechanical hemostasis with clips or thermal coagulation. There are lots of adjuncts available on the market now, And even since I started training in gastroenterology, there have been a significant number of developments. So it can be a little bit confusing about what to use, but the important thing to say is that dual treatment is better than single treatment, and you need to have everything available and be comfortable with the entire arsenal that you have, because not every bleeder is the same. And being comfortable with a wide range of tools and being able to adapt to a wide range of anatomy, if the lesion's at a very tricky to treat place, you're more likely to have a successful outcome. So you can see consequences of portal hypertension, such as portal hypertensive gastropathy or GAVE, gastric antral vascular ectasia. You can have angiodysplasias, severe esophagitis can bleed, Guilfoyle lesions, which are rare and difficult to identify, but can cause significant upper GI bleeding, erosions, all sorts of things. Upper GI cancers are a tricky cause of upper GI bleeding to treat, and sometimes they require a bit more cross-specialty management. However, things like that I mentioned, like adjunctive treatment, such as hemostatic powders, can be useful for these to temporize the situation.
So you mentioned about this added tools we have now available we didn't have 10 years ago when we started training, and I know in Edinburgh you have significant experience of using over-the-scope clips.
Yeah.
You want to talk us your experience on using those?
So I think that they have actually really revolutionized the management of peptic ulcer bleeding, where you have a large visible vessel, and Guilfoyle lesions as well when required. When I started training, we used to send a lot of people for interventional radiology and embolization because the vessel that you were faced with was simply too big for any of the modalities that we had at the time. So often what we would do would be inject some adrenaline, place a clip adjacent to the lesion for marking, and send the patient for prophylactic embolization. The Ovesco, we used the first one in 2016, or the overscope clip. There are a few versions available, and that instantly meant that we could treat those patients definitively in the endoscopy room. Initially, the studies supported their use in re-bleeding. However, there is now growing data to show that it's legitimate to use them for large non-bleeding visible vessels, or actively bleeding large vessels that you think are too large for conventional endotherapy. And we have an extensive experience of doing that, and with low risks of re-bleeding, and they have been very effective. And as a result, our referrals to interventional radiology have reduced.
Do you think that upper GI bleeding that requires endoscopy is safe to be done under sedation? When is the role for general anesthetic?
Yes, I think if you have a stable patient who is not requiring ongoing active resuscitation at the time of their endoscopy, then it's okay to do that in the department with the endoscopist providing the sedation. In an ideal world, of course, it would be one less thing to think about if you had an anaesthetist dealing with that, but we have very limited access to that across the UK. If the patient is requiring ongoing resuscitation, if they have active bleeding with a risk of aspiration from blood in their stomach, then I think it's essential that those patients are done in theatre with an anaesthetist protecting their airway and concentrating on their resuscitation, so that the endoscopist can get on with the job of diagnosing what the problem is and working out how to treat it.
You mentioned already that your referral to interventional radiologists has dropped since the use of Ovesco clips, but is there still a role for IR or surgery in peptic ulcer disease?
Absolutely. So the interventional radiology referrals have dropped, but we still do make several referrals. If the lesion is not accessible endoscopically or treatable endoscopically, I can give you an example. Recently I had someone who had unexpectedly Forest 1A, spurting arterial bleeding from a peptic ulcer, but also had an esophageal stricture, so it wasn't possible to get any type of endoscope down there other than a pediatric scope, which has very limited options, so that patient went for IR. Not every lesion is amenable to endoscopic therapy. It's too big or in too awkward a location, and in those situations we'll send them for interventional radiology. Equally, surgery now in our unit is rare. And the BSG bleeding audit from 2022 reflects that, in that there was a reduction in the rates of surgery for peptic ulcer bleeding. However, if you've got an unstable patient who you're taking to theatre because they're bleeding from peptic ulcer disease, that can be a very difficult situation to control endoscopically, and the patient may not be stable enough to go for interventional radiology. So those are the patients I will give my surgeons a heads up and say, taking this patient to theatre might need some help. And we've done a few laparotomies in the last 4 or 5 years for the surgeons to oversew a bleeding duodenal ulcer.
Assuming we have treated the lesion endoscopically, achieving hemostasis, what should happen after to the patient?
So they, again, depending on their risk of rebleeding, which we can use the Rockall score to estimate, we should be in a place of safety where rebleeding can be recognised. They should have been tested and treated for Helicobacter pylori if that's present, because that will reduce the risk of rebleeding. And we should give them proton pump inhibitor therapy. Generally, that will be done for a period of 72 hours, either as a continuous infusion or as bolus.
When should we restart anticoagulation or antiplatelets?
So this is a really good question, and I'm not sure anyone knows definitively the answer. I think you have to take it on a case-by-case basis, looking at the indication for the patient's anticoagulation or antiplatelets. You have to think about what the risk of rebleeding is for that patient that's in front of you. So if you've gone down, you've seen a tiny visible vessel that wasn't bleeding, you've treated it, you think there's absolutely no way that's going to rebleed again, you'll feel reasonably comfortable starting anticoagulation again or antiplatelets again quickly for that patient. In higher risk patients, where they maybe have a mechanical mitral valve which requires ongoing anticoagulation, but they also have a high bleeding risk, that may be something that you want to liaise with your hematology colleagues with, or your cardiology colleagues with, to try to come up with a consensus about appropriate risk stratification there. And it does have to be taken on a case-by-case basis, because it's not something you can really cover with guidelines.
What about aspirin?
So aspirin, again, depending on the indication, should be restarted as soon as you feel that it's safe to. It's probably lower risk in terms of initiating rebleeding. Clearly it can cause peptic ulceration, but you can start that safely once you're happy that the patient has hemostasis secured. I think the unquantified risk that we have in patients who are on antiplatelets, anticoagulation, is the risk of stroke or myocardial infarction when we go in and stop these things and perhaps don't restart them in a timely fashion. And certainly with aspirin, I would have an inclination to restart that as soon as I was happy that the patient's rebleeding risk was reducing.
So we are now very good at treating upper GI bleeding. We have loads of tools that we can use. Certainly you're very confident with that. Very little role for IR or surgery because of it. With all this, is the mortality of upper GI bleed changed?
It has decreased slightly. So in the 2007 audit, it was about 10%, and it's now about 8.8%. That's still significant in my view. And if you look at patients who are already inpatients in hospital, who are in with another pathology, who develop upper GI bleeding, the mortality is closer to a quarter of those patients. So that is very significant. So this is still something that we have to treat seriously. We probably have further work to do, and I think we can reduce that rate further as time goes on. That has to be counterbalanced with the fact that we have an aging population who are becoming more comorbid, and almost a significant proportion of patients now are on antiplatelets and anticoagulants. So our job is getting a little bit tougher in that regard, but despite that we have seen some modest improvement.
Do you have any take-home messages for our listeners?
What I would say is endoscopy is important in upper GI bleeding, but it is probably less important than everything else that goes around it. So the recognition, the risk stratification, the resuscitation, and the appropriate peri-procedural care. If we get all those things right, the patients are likely to do better. As gastroenterologists, it's on us then to, when we're down there with the scope, recognize exactly what the lesion is and recognize what treatment is likely to be effective and safe. If we can deliver that, we can prevent rebleeding and we can prognosticate for the patient. We also have to be aware that this is not a one-man band, and we can have colleagues who can help us if we're struggling. So every hospital is different in its setup. Some hospitals don't have reliable access to interventional radiology, for example, and in those places perhaps the surgeons will play a more important role in the management of difficult bleeding. But I think it's important to use your local resources in order to effectively manage the patient that's in front of you. I guess one other important paper to be aware of is the HALTED trial, looking at the use of tranexamic acid in upper GI bleeding, which showed that there was no benefit to giving tranexamic acid in terms of reducing bleeding, with a slight tendency towards increased venous thromboembolism events. And so, again, unlike trauma or surgical bleeding where that is given liberally, we should discourage the use of that in upper GI bleeding.
Well, only what is left for me to say is to thank you for this wonderful run through this very relevant topic, and to thank you for joining us for Digest This.